Her relevant medical history is significant for rheumatic heart disease and pre-existing mitral valve stenosis. Her surgical history was appendectomy and cholecystectomy. So again, she's presented with disturbed conscious level, right hemiparesis, and aphasia. On clinical examination, we assessed her vitals, including heart rate, blood pressure, and random blood sugar, and the neurological deficit using the standard scale. She scored in the initial NIH score 14. This confirming a large vessel occlusion for urgent diagnostic and therapeutic approach. So this history strongly suggests that the etiology of her stroke was cardioembolic, a clot originating from the heart and traveled to the brain, leading to her acute neurological symptoms. An ECG and echo were also performed. CT and MRI was done. Our diagnostic workup started immediately by the initial CT brain scan, and it showed key early signs of acute ischemic thrombus, include the hyperdense MCE sign, which is not specific, the insular ribbon sign, and loss of gray and white matter differentiation. These findings further localized the occlusion of left middle cerebral artery territories. We performed then the MRI stroke protocol for a detailed assessment. We utilized the standard sequences, diffusion, ADC, flare. Diffusion and ADC sequences shows diffusion restriction in the insular area, being hyper-intense in diffusion and hypo-intense in ADC, and the flare sequence show also hyper-intense area. SWI is free and is used to detect if it associated with hemorrhage or not, which is already excluded in the CT. The MRI was vital for determining the salvageable brain tissue and guiding the interventional decision. So in this case, the stroke is of acute stage, being hyper in diffusion and hypo in ADC, and hyper in flare. And this is due to the vasogenic edema happened in early stroke. So based on the severe clinical deficit, the high NIH score, and positive finding in CT and MRI, we proceed to perform the diagnostic angiography. And this video shows that the left middle cerebral artery is abruptly cut off with poor or absent flow into the smaller distal branches. So this confirmed large vessel occlusion, and this is the target of our intervention. The next step was immediately mechanical thrombectomy. This procedure was performed to mechanically retrieve the thrombus to restore the blood flow to the ischemic brain tissue. This final angiogram video shows post-thrombectomy. As we can clearly see, we have achieved successful recanalization. The entire vascular tree is now filled with the contrast, demonstrating excellent perfusion to the distal vessels. This outcome significantly improved the patient prognosis. So steps for mechanical thrombectomy: first, patient selection, large vessel occlusion, including the internal carotid artery, M1 or M2 segments, or basilar artery, within 6 hours. Sometimes it will be raised to 24 hours according to the favorable imaging, confirmed on CT and MRI also. The access: femoral artery puncture, sometimes radial artery puncture, introduced our sheath, advance a guide catheter to the cervical part of the internal carotid artery. Then a microcatheter over a microwire is advanced in the intracranial circulation, crossing over the clot under fluoroscopic guidance. Our thrombectomy technique may be stent retriever technique, which is used in this case, aspiration technique, or combined. The stent retriever technique, we use solitaire is deployed through the clot and embeds into the thrombus and temporarily restores some flow after a few minutes. The stent and the clot are pulled back into the guide catheter. The aspiration technique, a large bore aspiration catheter is placed at the face of the clot. Continuous suction is applied. The clot is aspirated out directly. Combined technique, we use the stent retriever and the aspiration catheter together for a higher successful rate. After clot retrieval, we form a confirmatory angiography. Multiple passes may be needed, up to 3 passes.
Ever wondered how doctors remove life-threatening blood clots from the brain? It's done through a procedure called mechanical thrombectomy. This is a life-saving treatment for stroke patients caused by blocked arteries. Here's how it works. The patient is given anesthesia or sedation, and a small incision is made in the groin or wrist. A thin, flexible tube called a catheter is inserted into an artery and guided all the way up to the brain using real-time imaging. Once the clot is located, doctors use a special device, like a stent retriever or suction catheter, to grab or vacuum out the clot, restoring blood flow instantly. The catheter is then carefully removed and the incision is closed. This procedure can drastically reduce stroke damage and improve recovery chances.
So our take-home message from this case is time is brain, rapid recognition of large vessel occlusion, multi-modality imaging as CT and MRI and confirmatory angiography together to guide us to our interventional plan. Mechanical thrombectomy is the definitive treatment for large vessel occlusion and offers best chance for a good functional outcome. Complete management, the care must be extended beyond the intervention to include proper cardioembolic stroke management as in this case, to address the underlying cause, rheumatic heart disease and mitral valve stenosis to prevent future embolic event. Thank you.
شكرا يا دينا على الكيس برزنتيشن دي، والحقيقه انا احب اشكر دينا وحبيبه مش على الكيس برزنتيشنز بس، ولكن على الكونتريبيوشن بتاعهم في البيشنت بريباريشن والبارتيسيبيشن فعلا في الميكانيكال ثرومبكتومي على ارض الواقع، والمجهود العظيم اللي هم بيقدموه في الواحد. فبشكركم جدا على مجهودكم. Now the floor is open for few questions if there is anyone want to ask one of the speakers. The panel, any questions? So we now come to the end of this session. Many thanks for all the speakers, the panelists, and the audience. And we invite you all to take a picture, collective picture with the speakers and the chairperson.